Hi, Dr. Brian Koffman, a family doctor turned patient with CLL, and I'm here at ASH 2013, and I'm going to be speaking with my friend Dr. John Pagel. Dr. Pagel, you want to introduce yourself?
Sure, it's great to be here. I'm John Pagel. I'm from Seattle. I'm from the University of Washington and the Fred Hutchinson Cancer Research Center there in Seattle, and I'm a CLL doctor, so it's good to be here.
So one of the things I haven't talked with anybody about, and I know that you have a poster on this and have been involved in research, is using these radioimmune antibodies. You want to walk us through a little bit of the background on that and what your poster showed us?
Sure. Well, radio-labeled antibodies are not new. They are something that we've had around for a decade, or actually more than a decade. The idea behind it is it's targeted delivery of radiation. Of course, we know radiation can work to treat tumors if we deliver it from an external source or external beam, but maybe what we can do, the theory was many years ago, is that if we can target the radiation directly to the cancer cell and limit all the radiation that's going to the normal organs that you might get from external beam radiotherapy, you could escalate the dose higher and you could actually do it with relatively minimal toxicity. And that's actually the premise behind a radio-labeled antibody. It's a biological vehicle to deliver radiation. So it's like a car driving down the highway, and the highway is the bloodstream that gets introduced intravenously, and is looking for its parking spot. That biological car is looking for its parking spot.
I love your analogies.
Yeah.
I just love them. Yeah.
Well, it just puts it in perspective, right?
Yeah.
And so the parking spot in this case is CD20, but you could engineer your antibody to park
Which is found on all B cells.
pretty much
good
all
and
these-
bad.
Good and bad, that's
Right.
right. And that's the target that rituximab is directed towards, same for ofatumumab or now GA101.
Or obinutuzumab.
Obinutuzumab, as I should say, yeah.
Yeah.
And so we target that CD20, so you park in the parking spot there. Maybe hopefully you drove past the liver and the lungs and the kidneys and you didn't get much radiation exposure there. And you park at that CD20 binding spot on the surface of the CLL cell and drop off the luggage, and that's radiation that might be in the trunk of that vehicle. And then that radiation locally will kill the cancer cell. And actually those drugs, there have been two that have previously been commercially approved, Bexar and Zevalin, approved for indolent lymphomas. They're very efficacious drugs, but they're not widely used. One thing that has been a problem is trying to find a niche where those drugs should be used. Several years ago, some really outstanding scientists, in particular led by Ollie Press, developed this idea of maybe using a radio-labeled antibody as consolidation after some prior treatment. So maybe you would get some induction chemotherapy. In the case of CLL, maybe it would be FCR or something like that. And then once you get a remission,
So you use the induction therapy to induce a low tumor burden,
right.
And then you use this for kind of a mop-up, is that?
Exactly. So it's a consolidation, it's a mop-up, because we know there's still malignant cells circulating around somewhere because disease typically will come back. So the idea is that maybe we can mop up that low level of disease and actually have an impact in the natural history for individual patients. And actually what was shown when this was first tried in follicular lymphoma is that that's in fact very feasible. You can actually take patients and you can actually, if they got a remission, but it was only a partial remission, and then you give the radio-labeled antibody, you can convert that partial remission to a complete remission. Or if you had any evidence of what we call minimal residual disease, and now this is the big thing in CLL as well, maybe you can't see any cells in the bone marrow as an example, or something under the microscope, but we know those cells are there. We can do more sensitive tests to look for those cells.
Right, so when the old school pathologist is looking through the light microscopy, he
Right.
says there's no cancer there.
Right.
But we've got more sensitive chemical tests that can found up down to what 1 in 100,000 cells.
Oh, absolutely. Or
Yeah.
maybe even with PCR, maybe you could get to, well, 1 in 100,000 cells, maybe 1 in 1,000,000 cells or whatever. So you can imagine if you could go from that being positive at 1 in 100,000 cells and eliminating that, maybe you're having a major chance towards curing patients. So we actually tried this in CLL patients as well. We're reporting on it here. It was,
And that's the presentation you have here.
yeah, it is. And basically patients could get, for their first-line treatment, whatever their doctor felt was appropriate for them. So it might have been FCR or FR or BR or what have you, or maybe just even single-agent rituximab. But once they got a remission, either a complete remission or a partial remission, we came in and we gave one-time dose of the radio-labeled antibody and found that for the vast majority of patients, whoever was in a PR got converted to a CR, and we eliminated minimal residual disease in the vast majority of the patients who had evidence of it after their upfront induction therapy. How that will translate to outcomes for patients remains unknown. People have to be followed for long periods of time. But in general, in the relatively small number of patients, it was an encouraging approach. Where it gets used in CLL is unknown, but it's probably unlikely to be widely used. And that's for lots of reasons.
Yeah, so talk to us about that, because it seems so promising, but it's so underused.
I think there's a big reason, and that's that there's so many other drugs that you can use now in CLL, and thank goodness that there are, right? Now we have all these new oral targeted, what we call tyrosine kinase inhibitors, or we have inhibitors of BCL2, or we have now new antibodies, and there are many more in the pike. And so it's hard to maybe use a drug that you're not as familiar with when you have all these other choices, and we know people will tolerate them well, they're going to do well, so somebody's going to lose out. And historically, the radio-labeled antibody might have lost out a little bit because it's not delivered by an oncologist. It's typically delivered by either a radiation oncologist or a nuclear medicine physician. And so to navigate your way to those kinds of doctors to receive that kind of therapy can somewhat be challenging, especially when you're navigating through 10 other different treatment choices to get there, and there's nothing wrong with those 10 other choices or more. So this was a promising approach, and I think what I take away from it is maybe not despair to say we're not going to use radio-labeled antibodies much, but this idea that it is feasible and perhaps quite important to convert partial remissions to complete remissions and eliminate minimal residual disease in CLL. And I think that's a big endpoint that we're now starting to look at, minimal residual disease. And if we can get rid of that by those very sensitive tests that you mentioned, maybe what we can do is work towards curing this disease without doing a stem cell transplant, just with standard treatments.
So let me ask you, one of the issues for its use in CLL, which is confusing because it's leukemia and lymphoma versus lymphomas, was bone marrow involvement. And don't you have to have a very low level of bone marrow involvement? Because if you have a significant bone marrow involvement when the radiation in the marrow cause significant damage, isn't that one of the criteria you have to look at using this drug?
Yeah, and that's the theory, that if you deliver too much radiation by targeting too many cells in the bone marrow, you're going to kill some of those normal cells that might be neighbors to your malignant CLL cell. And if you kill too many normal cells, maybe the bone marrow doesn't regenerate. So you need to have less than 25% of the bone marrow being involved with CLL. It turns out in the setting that I described, in the upfront setting where people get some treatment and then get a remission, no one typically would have more than 25% marrow involvement, if any marrow involvement, of significance. So it's very feasible to do this in that setting. Again, of course, albeit with all the challenges to get patients treated with radio-labeled antibody.
And can you kind of briefly, in a minute or so, just give us kind of an overview of any late adverse events with this or any other problems you see?
Well, that's, of course, a major important point, and what many people have always rightfully been concerned about are late malignancies, secondary malignancies, and in particular myelodysplastic syndrome and or acute leukemia. There is a real risk with any treatment that we do of having late complications. Certainly we know chemotherapies can cause these second cancers, very rarely, and radio-labeled antibodies can as well. The risk is real, but it's low, it's very low. So in the patients that we've treated, we haven't seen that in this trial that I've talked about. But again, we have to follow people for longer periods of time to make sure. But I would summarize by saying it is a real risk, but it's an extremely low risk. And something, however, to keep in mind.
All right, so let's hold there and we'll come back to some other exciting trials in a minute. Thanks.
Great.